I've been using a deck of slides with various partners across the ICS, and that stems from Healthwatch, and it stems from Oxford Brookes University, and you name it. Now, what I've done is to pull out 4 slides, or maybe it was 5, which I think are kind of most relevant. But if I'm missing bits, then I'm very happy to take questions. Just to recap, I mean, the reason why we're putting integrated systems together is to achieve these 4 goals. So one is improving outcomes in population health and healthcare. And I make the point quite emphatically when I'm talking to partners, this isn't just about the NHS. This is in Bob about the 1.8 million people that we're responsible for the health and well-being. So it very much includes a local authority. It includes community, and obviously it includes the voluntary sector as well. The second of the 4 goals is recognizing that there are real inequalities in the way that health and well-being can be experienced and accessed by various groups within the communities. COVID made that really clear, but we knew it anyway. I don't think we've done enough about, so what do we actually do with that? And it can be, I think, a lot to do with delivering or providing access very differently to some groups, rather than just trying harder with the standard model. So that's one of the 4 really important goals set for ICSs. Clearly, productivity and value for money are there. And it's very important to even with the sort of cost pressures that we're inevitably going to have, even with all the money that's coming towards the NHS, maybe it's less so perhaps to the social care centre, but it is about value for money. And here is one of the routes into innovation, I think, in providing health and care to populations. So part of it is kind of rethinking some of the care pathways, thinking about how we can support residents, maybe prevent them becoming patients in our communities, rather than wait until they're in need of care and then having to exercise a more expensive solution, I suppose. Productivity as well. This is about collaborating at one level. I mean, it's about innovating in care pathways, but it's about particularly hospitals not doing the identical thing competitively side by side, but being able to find a way of being able to get some procedures done more in one hospital and other procedures done more in another hospital. So as we look at the recovery from COVID, there are a number of areas, but one example would be cataracts. There's a long backlog of cataracts. Rather than letting everybody do a bit of cataracts, there's a move to try and find a way of being able to, I won't call it a cataract centre, but that's a sense of what I mean. So we can improve the volume of care that we're giving to people without jeopardizing the quality. And then the 4th element of it is about supporting the broader social and economic development. That's recognizing really the NHS employs 1.3 million people, but also impacts on an awful lot of the viability of our communities. And rather than being introspective about what we do, it's making sure that we have a role to play in the broader communities. Now, these goals were set in the long-term plan, if you're familiar with that, which was launched over 2 years ago. So the creation of the integrated care systems is a organizational delivery response to the long-term plan. I've tried to keep this simple. So this is an example in my ICS. So Buckinghamshire, Oxfordshire and Berkshire is one of the 44 integrated care systems that are anticipated to become statutory bodies in April 22. There will be in each of the 44 a kind of a grouping called the Integrated Care Partnership. Now, this will include NHS, local government, Health Watch, voluntary sector, and I won't put a definitive list out because it won't be definitive. But the role of this group is to create a care strategy for the ICS. Now, clearly, there'll be support coming from executive staff in terms of the kind of analysis, but it will tend to draw from the communities and the local authorities upwards and marry together the needs of populations with the, if you like, the kind of national direction on items like cardiology, mental health, and so on, to produce an overall care strategy. This group will be chaired either by well, an example would be me, but either or it will appoint its own chair. It will be a group that probably meets as a sort of partnership. I hesitate to say board, but as a group, probably, I don't know, 2 or 3 times a year. But I envisage that having a much broader network of stakeholder events and local community events that will feed and connect up to it. So the health and well-being boards, for example, in the local authorities and the community groups within the primary care networks, we have got to build how we want that to connect together. There is an expectation it will be knitted together, but it is up to each ICS to work out the best way of doing that. The next body, and this is, I suppose, probably a more recognizable body, is the Integrated Care Board. This is the statutory body which will be responsible for the NHS money that comes into the system. So, for example, in Bob, it's over £2 billion worth of funding, so it's an awful lot of public money. So, of course, there will be statutory and governance responsibilities. But its role is to respond and produce a delivery plan to satisfy the care strategy produced by the Partnership Board. So the Partnership Board sets the shape, and the Care Board, if you like, gets the detailed executional planning in. How well will that work? Well, I think the intention's right. There's a bit of a habit in the NHS of going, yes, but we know how to do it, so this is the way it's doing. So thank you for your plan, but we're getting on with it. And I think the accountability on that board, with local government representation sitting on that board, an independent non-execs chairing the audit committee, independent non-execs chairing the remuneration committee, that there will be a good balance. These are not big boards, so it isn't everybody it isn't every trust chair, for example, sitting on the board. They're quite small. They do have representation from primary care, from the kind of providers, and also from local government. The next level is down to sort of place. So in Bob, this is Buckinghamshire, or it is Oxfordshire, or it is Berkshire West. And of course, the local government structures are different in each of those. So the nature of the place-based partnerships will be different too. But there will be 3. And we are in the process at the moment of creating these place-based partnerships and looking at how a lot of the resources that come into the ICB are then distributed out. So the idea here is that within an agreed framework, and the framework is driven by the Partnership Board, that an awful lot of funds and accountabilities or responsibilities for delivering the plans will be moved down to places and down further into primary care networks. And just for those of you that are familiar with the NHS at the moment, it means from April 22, the CCGs no longer exist. So they cease to be the statutory bodies that they are. All the CCG staff move into the ICB, and I'll come on to explain the ICB will take over the CCC's statutory responsibilities plus some more. One of the key bits that the ICS should do on behalf of the system and with the system is to set direction. And the bit I've highlighted here, and I won't go through all of these, but it's about population health analytics. We want to put a real focus on the impact and the need in population health rather than the number of operations we're doing. And frankly, if you read the papers and we look at the COVID recovery plan, all the government will talk about is the number of operations. But in the direction setting, we must be looking at the impact on population health. And it's not just the clinical health, it's also the well-being and mental health, as I think I'll come on to say, is going to be a really key plank of that activity. I won't go through these other two, but I mentioned resource allocation and, of course, commissioning of activities. This is one other slide that I pulled out, that the responsibility in the system is to support and strengthen primary care. So there's a real fear from colleagues when this came in that this was going to be another layer of management. It's all going to be done at the top and it would be ridiculous. Well, it would be ridiculous, and that's not the intention. So a clear mandate here to support and strengthen primary care. So the primary care networks, the PCNs, which can work at community level, and individual practice development needs to be then, frankly, there needs to be some, it's not only resource, but also some management skills support, and that will be going in as well. Improving the care of patients. So this is about, if we're going to support and put resource in and move things, we need to make sure that it really is improving the care rather than we're just busy doing a lot of things. So that, again, that connection with outcomes. And of course, the prevention and proactive care. This has always been a difficult area in health because the payback is longer term than fixing something now. But it's really, really important. And we've seen, if we think about diabetes and think about the requirement to think about diet with children, there are some very, very strong links as well. So that it's got to be on the agenda. And I would hope that the partnership board and the ICB will keep asking the question about, are we doing all the things rather than purely doing the recovery program on the operations that got missed. Final slide here. So it was just kind to lay out the core functions, and I've touched on some of those. The one in orange I've highlighted as well, because public and stakeholder and patient engagement is a must do. It is a real must do, and we need to connect between communities and what they provide. It isn't going to be purely a kind of representative professional patient panel at Bob level. That's hopeless. So it will be working with local communities to make sure that the requirements not only of the care needs, but how care is delivered and how it is experienced. So it's partly to do with the inequalities, but also to do with designing care in the right way. And I mention that because a lot of the work that you do and that NCCH are interested in, it's not fair to say unconventional, but it's certainly not in the sort of medical school clinical sort of directory. There are ways in which people need to experience the support, and that will be a responsibility there.